want to be a shift worker. One of the unfortunate conditions for emergency physicians is that the way in which they get compensated, their employment model has them being shift workers, and they don't like it. At least some don't like it. The ones that don't like it, that want to break out of it, often look for entrepreneurial models in order to escape from the shift working world. So either physicians in general work for a large contract company, with Team Health or MCare being the gorillas, or they work for a hospital and they're paid an hourly. Someone is paying them as little as possible in order to make as much money as possible. Someone is taking away a significant amount of what they generate and keeping it for themselves. So entrepreneurial physicians, people who want to get out of that world, I would say are entrepreneurially inclined, and they look for other opportunities, both within the specialty and outside the specialty, in order to escape from the shift-working world.
Now, that's interesting, because I have heard emergency physicians described as the gunslingers of the medical world. That one of the attractions to going into emergency medicine is that you, in effect, are shift workers. That you're going in there and you're spending 8 hours or 12 hours or whatever.
I'm laughing. Because they're not gunslingers. They're migratory workers. They migrate across town or across states in order to make another $5 an hour, $10 more an hour. That's not the behavior of gunslingers. I think that glamorizes it. I think that in emergency medicine, there are basically, let's say, 15 problems that occur again and again and again. The good physicians develop an algorithmic approach to those problems, and quickly realize the challenges in addressing the patient's holistic needs, as well as making a diagnosis or performing procedures. So while I certainly, as an emergency physician, enjoy the variety and the pace, of working a shift, after residency and a few years of practice, it becomes fairly routine, and it becomes basically shift work. So the people who were, I think actually the specialty, and I'll just back up a moment and say that when I went to residency, there were not attending physicians in the ER. We really were on our own and dealing with things that were unexpected in ways that we did not know yet how to often to deal in a consistent way with problems. But the specialty has emerged as evolved and developed standards, and it's become, I think for a lot of physicians, find to be a routine, relatively well-paying routine, but a routine, and they look to get out, and they look to get out by thinking about, well, gee, should I start a cosmetic practice? Should I be squirting some Botox? Should I be learning? Should I what can I do? What can I do to get control over my life? Because the problem in emergency medicine is that a lot of physicians don't feel that they don't make enough money. I mean, this is actually a general problem in healthcare right now. From the outside, people look at physicians and say, "Oh God, they make a lot of money." From the inside, if you're a guy who's making $300,000 a year and you have 2 homes, 2 wives, 2 kids, and you want to take 2 vacations a year, and especially if you're living in a high-tax state and you have your kids going to private school, there's nothing left over. So I think that a lot of physicians are looking aggressively, not the majority, but looking aggressively for other opportunities.
This sounds, it sounds as though you've had you've gone through exactly this, this kind of curve that you started out. Were you always this way? I mean, were you sneaking into the business, the business school at Harvard, or did you consider yourself to be an entrepreneurial student then?
I came to it. That's an interesting question. For me, philosophically, I went from I majored in Slavic language and literature at Harvard. As a result of taking classes taught by Marxists, I became an anti-communist, and that eventually led to my becoming a capitalist, at least philosophically. But it wasn't until I was relatively old, in my mid-40s, that I felt that type of money that I was making, working for a hospital, running an ER, would not be enough to provide the type of lifestyle that I wanted for, a family of 5. So it was that, so my first business was starting an emergency medicine company at one hospital, and then that became 3 hospitals, and now it's 16 hospitals. And that model was an attempt to address the 2 problems I think we're getting at in emergency medicine. One, I want to transform shift workers into owners, and that's part of the model of my emergency medicine company. I want the benefits that come from the visit. I want to give a profit in order to have physicians who are thinking and acting like owners. That they're going to be more responsible and more accountable as a consequence of owning the business. I also didn't want to be a vendor of services to hospitals. I want to write a business plan with hospitals that objectively looked at the parameters that were necessary for quality and profitability in an ER. Measure those, set goals, measure those goals, and deliver high-quality emergency medicine and operational and financial success to both the ER group and the hospital. That led in turn to my interest in telemedicine.
So how do you kind of balance? There's 2 things. There's kind of a push-pull. You're trying to provide ownership to the physicians who are working inside of the system. At the same time, they're providing a service to generally probably for-profit hospitals that are attempting to make as much profit as they can.
Well, even the nonprofits want to make profit.
Sure. And so how do you manage that on both sides? Meaning, how do you align the individual physicians so that they both feel ownership and manage the expectations of the hospital that you're delivering services for and their need to create a profit?
We want the physicians to be invested in the contract from the beginning, and then we want to incentivize parameters that address quality and financial success for the physicians. So I'm basically taking the model, as opposed to the shift work model, what we're really doing is we're partnering, the management companies, partnering with the physicians to build a private practice. So for example, and this is a model that's used outside of emergency medicine, if an ENT or an ortho or an OB or a surgeon is going to town and joining a practice, they want to know, they don't really care about their hourly. They want to know what's the practice worth, what's the buy-in, how long is it the partnership, and what's the growth potential of the practice. So we model all those things for our physicians. So they understand if they invest, they understand what they can make. Because of our experience, we can project what the growth is going to be. And because we're concerned with both operational and financial success, we also, within the contracts in general, have incentivized. Could be customer satisfaction scores, it could be walkouts, it could be length of stays. We incentivize the things that will lead to operational and financial success. On the hospital side, I discovered that hospitals, I know it's going to shock you, don't care that much about quality. It's not their primary mission. They care about it, it's not their major concern. What they care about is profitability. In New Jersey, where I started Pegasus, we had Press Ganey scores in the 99th percentile. I thought that I'd be able to market that to hospitals. And I was able to pick up a couple of contracts. But when I rebranded Pegasus 2.5, 3 years ago, I focused on hospital profitability. And what drives a hospital to be profitable in the ER? Elimination of walkouts. Every patient that walks out, even if they're not paying, is your reputation walking out the door. Improving documentation. We will not take on a contract that uses paper. We need electronic medical record in order to have operational and financial success, as does the hospital. For every dollar we make, the hospital makes $2.5, $3. And when hospitals are leaving that money behind the table, they are leaving behind the oxygen, the oxygen that they need in order to run successful programs. We also want to be certain that patients who meet the admission criteria are admitted. Those are appropriate admissions, and we want to write a marketing plan with a hospital in order to increase the census in the ER. So that's the Pegasus model, and it's different.
So you've been successful tracking the emergency physicians that are looking at this. They find that novel. Are there other people that are using the same approach, or do you feel like this is something that you are kind of leading the charge on?
I don't know anyone who uses this approach, but there are people who talk about it. What we're trying to do is bridge the gap between what the consultants recommend and what is actually delivered. So there are consultants, the Studer Group, McKesson, et cetera, that tell people they should be doing what I'm saying. But I don't know anyone who's doing it as comprehensively and as aggressively as we are.
And so you brought up yet another interesting point, which is, so who in this, who in the scrum here is actually the biggest proponent for patient care?
We are. Because the hospitals are looking for someone to manage their problems in the ER. They don't. So we market ourselves to as not as a vendor. We're not plugging. We're not plugging widget doctors into a schedule like our competitors, large competitors. We're partnering with a hospital to achieve certain objectives, and we're agreeing in advance on what those objectives are and what is necessary in order to achieve those objectives. So
let's talk about telemedicine now.
Sure.
How did you get involved in that, and how did that how did that germinate?
Yeah, well, this is what there's actually you could argue that there's a contradiction between telemedicine and the emergency medicine business, and there is, because telemedicine is really transformational. I mean, telemedicine is a reaction to the crisis in healthcare. If we're really going to change healthcare, we have to replace the 19th century healthcare model of expensive brick and mortar and expensive physicians with technology and technicians wherever possible, and achieve the type of cost savings and efficiencies that have been realized by computers, in the rest of the economy, but not in healthcare. Healthcare is expensive, it's inconvenient, quality is indifferent, and you have to ask yourself why. And the reason is, in my opinion, strong opinion, that physicians in hospitals are driven by a reimbursement menu. In addition to which physicians practice defensive medicine, and we have traditional practices, like the ritual, the ophthalmoscope, stethoscope, reflex hammer, that just basically waste time and don't lead to any any additional information. Do you know how pricing is set in healthcare?
Well, I've always referred to this as the coding dance, but you go ahead.
It is. So that's basically managed care. Medicare sets prices for 7,800 items. Managed care pays some multiple, and this is a dumb socialist model. If if Medicare is going to pay $38 for a physician visit, well, that'll buy you 2 minutes of time 2 weeks from now with a mid-level. If they're going to pay $440 for an abdominal CAT scan, well, physicians will CAT scan people till they glow. And it's wrong. And what you're getting at is the upcoding problem. Hospitals and physician groups have offices, staff, capital equipment that are costly. So what do? They bring patients in. They then level up. They order tests, even procedures that may truly not be necessary. They rationalize that they're meeting expectations, that they have to be defensive. Patients aren't paying. But we don't really have a healthcare crisis. We have a reimbursement crisis.
Well,
driven by bad regulations. What do patients really want most of the time? Well, I know from internal studies, but I also know it's been studied by other people, that half the patients in ERs and 95% of patients in primary care offices, they just want advice and/or a prescription, but they can't get it because managed care and Medicare, in their don't care stupidity, only pay for physical contact. They pay nothing for advice. So physicians ration it. Matter of fact, they don't give it. If you call up an ER, they'll tell you, well, we can't diagnose it. We can't diagnose it over the phone. We have to evaluate you. But the truth is, they're being paid nothing for it. I mean, if Medicare paid $100 for advice over the phone, ERs and physician and offices would be empty.
You'd have phone banks.
So then, what are the two most common problems in healthcare? One in general healthcare. Well, the most common reason why people seek a doctor for trauma, is not something dramatic like a gunshot wound. It's an ankle sprain. for an infectious process is a sore throat or URI. Well, frankly, those are problems that can be answered by a computer. You don't even need a doctor for those things. We're really mismatching the resource, the problem as a consequence.